Thanks for this opportunity on sharing this talk on tips and tricks of removal of broken nails. I'm sure all of you have faced this problem of a broken nail sometime in your practice, and it brings new challenges all the time. I'm no expert in removal. However, we've had a few experiences, and I've searched some literature, so could share some tricks which you could have in your mind and apply them when you have your next case. So I think we should try and find out what type of a nail it is all the time. Keep asking for the prescription, the discharge slip, or the bills from the patient. The most common fracture site for a femoral interlocking nail would be the distal locking area. The next common would be the fracture site, and then it could also be the proximal locking site, and be where the nail could be broken at more than one site. So you need to plan out the case. You need to think whether you are going to do it open or closed. You're going to do it from the antegrade side or the retrograde side. About the fractured nail, you need to know where the fracture is. Is it at the fracture? Is it a single fracture? Is it locked both sides? Is it locked one side? Is it away from the fracture? And if it is away, which side is it? All these things, when you look at it more seriously, your plan will come in your mind. So ideal scenario, you should know the make, the length, and the diameter of the nail. If you know these details, it helps a lot. Preoperatively, try before, have a plan A for removal, and always have a plan B for fixation if your plan A for removal fails. Explain the patient regarding difficulties anticipated during surgery and possible outcome. Take whole length x-rays showing both proximal and distal end, both AP and lateral. Clinical examination of the patient, including palpation of the nail and locking bolts, helps at times. Range of movement at the adjacent joint. You plan a retrograde removal and the knee is stiff. Intraoperatively, you're stuck. And this has changed the scenario quite a bit. The conical extraction device, which helps you remove nails which could be of various diameters. It's a conical threaded implant which is very strong. So the tip is that you take it in clockwise and you get a hold on the nail. The problem could be if the conical bolt itself is in diameter more than the nail. So this won't apply over there. Once you've done, you've got your hold, take a deep breath and try to get a bit more of a hold. Don't be in a hurry. As soon as you get your first hold, take it out. And when you're taking out your nail, take it out in a way that you continue to have a clockwise hold while pulling it out. Easier said than done. In the operation theater, check your C-arm, if it's working or not. Discuss with the anesthetist as regard to anticipated difficulties. Any implant removal could be a challenge. A broken one could be a larger one. Paint and drape and position the patient in a way that you're going to plan, and ideally keep ready both the antegrade and the retrograde methods available in your paint and drape. Prepare yourself for the anticipated unforeseen difficulties. Don't rush to remove locking screws at once. Clean drape hua, remove your screws, I'll join you. No, don't do that. They should be removed sequentially depending upon your plan, and they prevent rotation and migration of your implant. So unless you get a hold on the broken part, don't start removing your locking screws. So there would be various instruments and implants which would be described in your textbook for removal of broken nails. If you have all these, it's always good, but if you don't have, try to see if you can arrange them in your operating room. So various described methods are AO recommends removal of proximal part of the broken nail and over-reaming of the canal till the broken part, and then removal of the part by various instruments, which could be the extraction hook. You could use solid reamers, you could use ender's nail, you could use femoral head corkscrew extractions, you could use grasping forceps, you could use long cockers. So the message is that you need some space. Once you remove the proximal part, ream it up, create some space so that you have space for your whatever instrument to go in and handle the distal part. So that is what is described. Once your proximal part is out, just clean up the near part with a reamer and create a space to get something in. Small nails, jamming of the canal with multiple wires, impaction of a K nail, maybe a solid nail, T-handle, bent K wires. So this is an example of a ball tip and a simple guide wire. If you are lucky enough and you can pass a ball tip wire through the distal fragment, and then be doubly lucky to pass a smooth wire. Once you passed both of them beyond the nail, when you pull the ball tip wire, the wires are going to get jammed. So anything broad you push first and then you put a smooth thing and you pull back the ball tip wire, the smooth wire is going to get stuck and you will have a hold. Single bent wire, you can pass if you're lucky and you can pass a single smooth bent wire. You can pass it through the bone, beyond the skin, outside the skin, and then over it you pass maybe a sleeve and remount the distal bone, bend the wire distally and then pull it back out. Might sound easy, but you need some luck again there. The same thing could be done from the antegrade side, and you can try to hook open the locking area, but it is easy, seen in this picture, but might not be very easy when you do it. When you pull on the fragment, this hook can just straighten off. If you're not lucky, your hook is not going inside, your hook is just going outside, just let it go outside and hook it from outside. So you get control on your fragment from the outside and then try to have luck, put a wire from inside, so you have a control from both sides. Again, you have to have a lot of luck here. In tibia, you don't have the retrograde possibility, so you can use the locking screw holes for manipulating the nail and getting it up slightly. You put your Steinmann pin in the proximal locking, jack up the nail a bit, then put it again in the distal locking, push up the tip a bit, and you can actually get it till the fracture site and maybe then pull it out from the fracture site. This might not be a very great idea to jam open the nail from below upwards or from upward downwards. The mandatory part is that the tip of the nail should not be facing anterior, otherwise you're going to end up below the patella. So if in the lateral view your nail is right in the area of the intercondylar notch and nothing else is working, everything is stuck, this could be the last resort that you just hammer it down using another long rod, which could be a solid nail or a cannulated nail, and the same technique could be used to push the nail up out of the trochanter. Again, multiple ways of doing it. Your smooth wire has gone in intramedullary, but then nothing is working. You can just pass a flexible nail through the locking area, and then when you pull the flexible nail and the straight wire, they can get jammed and then you can pull it out. So a case example, look close, it's broken at two areas. So probably there was a struggle when the nail was done. There were multiple holes made. So the options, open or closed. Problem, it's a segmental breakage of the nail. We decided to use a flexible titanium elastic nail. Go closed, go retrograde, percutaneous. So these were the steps. We got hold of each fragment, kept removing the locking screws, kept aligning the nail and then pulling it off, and suddenly we found that it was actually a bisegmental fractured nail. So advantages: atraumatic, no new instrument required, nails of different diameters can be removed, ideal if more than one nail fracture is there. We published this in Journal of Trauma, but then it can't be used in solid nail, tibial nail, K-nail, long nail, and stiff knees. K-nail, you can pass, if you're very lucky, you can pass an ender nail from the top, turn it 90 degrees and pull it out. It will be jammed that way and you can take it out with a T-handle. And if the breakage is proximal to the fracture area and you just can't pass a wire, any wire from the top, then probably it becomes a mandatory retrograde and you can put a ball tip wire or a washer and pull it out. So the take home message is there is no simple easy way to remove the broken nail, no universally successful technique for every situation. Equip yourself with all available ammunition, appraise yourself of all techniques. Multiple techniques together may bring success.